How do you diagnose endometriosis? And are most gynecologists trained to detect it?
Most gynecologists have not only been trained to detect it, but are very good at acknowledging what endometriosis is. However, the diagnosis, the gold standard, is what we call a laparoscopy, where a camera is put into the belly button generally, and under general anesthetic, and we actually can see the disease. And ideally, you would take a piece of tissue out as well, send it to pathology, and confirm that's endometriosis.
And what does it look like? What does endometriosis look like?
It's like the lining of the uterus. It's called endometrium in the uterus. It's called endometriosis. So it can look like black spots or blue or red. It's got a whole bunch of different ways that it may look like. But more importantly, what we try to advocate for through guidelines that I've been involved in is that a diagnosis can also be made on a good history, a good physical exam, ultrasound sometimes, so you don't have to wait to have surgery. If you're in pain, and this is the message I'll keep going back to, you need to treat the pain. And you have to figure out what best treatments you can go ahead with the pain. Surgery is one of the many things you may use to diagnose that you have endometriosis and treat endometriosis, but you listen to the patient first.
And I guess if you can treat the pain, then hopefully maybe that will the problem will look after itself. Or if the pain medication or whatever procedures don't work, then you move on to the next.
Exactly. We treat the pain so that they can get better, or you treat the infertility and you go see an infertility doctor, and you try to start with more conservative options. So as you've done in your book, surgery is great when you need it, and it'll work well because you do need it in certain circumstances. However, if you don't need it, you should try to avoid it. So treat the pain. If your pain gets better, you need to be monitored closely, make sure you're improving. But if it doesn't get better, there's so many options. I tell all my patients when I see them for the first time that we're going to start on a journey and we're going to try our best, but we're going to have to work together on trying to make you better. And we start with step one and we work our way up.
That alone must be hugely comforting for a lot of women to just know that, you know, finally someone's taking my symptoms seriously. Yeah. So let's talk about pain management. What's your protocol?
So pain management first starts with dealing with the pain, and it really depends on what their presenting symptoms are, but let's start with painful periods. So the simplest things to do are anti-inflammatories. If your pain's only when your period comes, anti-inflammatories have been shown to make your period pain better.
Like Advil or whatever?
Yeah, ibuprofen. There's a whole slew of different medications available depending on where your listeners live. And outside of that, the next step we may look at is the birth control pill. Now we call it the pill, but there's different ways to give combined hormonal contraception, patches, rings in the vagina. There's lots of different ways. But something that can either stop your period, so we give it continuously, so no period, no pain, and it's a very safe way to give the birth control pill or other things, or just give it on a monthly basis so that every month you have a period, but it's lighter, it's less painful. In many cases, that will help women deal with their pain. And I think that's a good start. Now, if that doesn't respond, they may need a referral then to a gynecologist who would then do a proper history and exam, and based on those findings, may move on to those other treatment options.
And when some women come to you ready for the next step, you can probably see it in their eyes and see it in their body language, and maybe they cry or whatever, that maybe the level of desperation is such that you know that they're ready for the next step, maybe?
Holly, I guess we should pause here for a second and really let you know that it breaks my heart every time a patient comes in who's suffered on average between 5 and 7 years with pain without a diagnosis. And they have, you know, had significant impact on their quality of life. They've lost trust in our medical system, and they're desperate. And like you said earlier, the most important thing that they feel comfort in is that somebody's going to try. And that's all that we promise at the beginning, and that's all often they need at the beginning, is that we're willing to work with them to make their pain and life better. And so we develop that therapeutic relationship with them and tell them, you know what, I believe you, that you do have pain, and I'm going to help you walk through to get better in this journey that we're going to move along. So it's acceptance of believing the patient. It's moving ahead that we've got treatment plans. We never promise that we're going to cure this issue. Pain is very complicated, and I think we make that very clear at the beginning, but we're going to help. And if we do get rid of the pain forever, that's fantastic. But if we don't, they know we're doing something, and we're going to make their quality of life better as well. So in review, we give a good therapeutic connection at the beginning and acknowledgement, and then we move forward with a treatment plan.